Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 243 of our pharmacotherapy series, which majors in endocarditis. The next question reads, BSB, a 74-year-old man with poor dentition, is scheduled to have all of his remaining teeth extracted for subsequent fitting of dentures. His medical history is significant for numerous infections of the oral cavity and prosthetic valve replacement 2 years ago. His only current medications are oral digoxin, marketed as Lanoxin, 0.125 mg per day, and furosemide, marketed as Lasix, 40 mg every morning. So my question to you is, what is the rationale for antibiotic prophylaxis? Because infective endocarditis is associated with significant mortality and long-term morbidity, prevention in susceptible patients is of paramount importance. Estimates are, however, that less than 10% of all cases are theoretically preventable. The incidence of endocarditis in patients undergoing procedures known to cause significant bacteremia, even without antibiotic prophylaxis, is low. In addition, endocarditis may develop after the administration of seemingly appropriate chemoprophylaxis. Therefore, it is not surprising that the efficacy of prophylaxis has never been established through placebo-controlled clinical trials. Approximately 6,000 patients would be necessary to demonstrate a statistical difference, if one exists, between untreated controls and a group receiving prophylaxis. Without conclusive clinical data from prospective trials, recommendations for antibiotic prophylaxis have been based largely on in vitro susceptibility data, evaluation of antibiotic regimens using animal models of endocarditis, and anecdotal experiences. Prophylactic antibiotics are thought to provide protection by decreasing the number of organisms reaching the damaged heart valve from a primary source. Thus, antibiotics theoretically prevent bacterial multiplication on the valve and interfere with bacterial adherence to the cardiac lesion. Compared with the previous 1997 guideline, the current guidelines only recommend the use of prophylaxis in patients with specific cardiac conditions associated with the highest risk of adverse outcomes from endocarditis, who are undergoing only dental or respiratory tract procedures. The use of prophylaxis for patients undergoing genitourinary or gastrointestinal procedures is not recommended because of a continuing lack of evidence to support efficacy. I will now briefly comment about dental and upper respiratory tract procedures. Analysis of published data shows that viridin streptococcal bacteremia can result from any procedure that involves the manipulation of the gingival tissue or the periapical region of the teeth or perforation of the oral mucosa. Placement or removal of prosthodontic or orthodontic appliances, adjustment of orthodontic appliances, taking dental radiographs, bleeding from trauma to the lips or oral mucosa, and instantaneous shedding of deciduous teeth do not require chemoprophylaxis. Endotracheal intubation also does not require prophylactic therapy. Antimicrobial prophylaxis should be directed against the viridans group of streptococci because these organisms are the most common cause of endocarditis after dental procedures. Invasive surgical procedures involving the upper respiratory tract, such as incision or biopsy of the respiratory mucosa, e.g., tonsillectomy, or adenoidectomy, can cause transient bacteremia with organisms that have similar antibiotic susceptibilities to those that occur after dental procedures, therefore, the same regimens are suggested. Prophylaxis is not recommended for bronchoscopies unless the procedure involves incision of the respiratory mucosa. Amoxicillin is currently recommended for oral prophylaxis in susceptible persons having dental or upper respiratory tract surgery. Oral clindamycin, clarithromycin, or azithromycin is recommended for patients with immediate type hypersensitivity reaction to penicillins. Only patients with outlined cardiac conditions should receive prophylactic antibiotics. Most cases of endocarditis caused by bacterial flora from the mouth do not follow dental procedures but rather are the result of poor oral hygiene. The cumulative exposure to random bacteremias from daily oral activities is estimated to be 5,730 minutes during a 1-month period compared with only 6 to 30 minutes for a dental procedure. Furthermore, it is estimated that the cumulative exposure to bacteremia from routine daily activities may be up to 5.6 million times greater than a single tooth extraction. Based on the study results, concerns for antimicrobial resistance, and cost, changes to restrict the use of antibiotic prophylaxis before dental procedures to the highest risk patients may be expected with future guidelines issued by the AHA. The next question reads, is prophylactic antibiotic therapy indicated for BSB? If so, which antibiotic or antibiotics should be used? Based on the current recommendations, BSB is a candidate for antibiotic prophylaxis. Presence of a prosthetic aortic valve while undergoing multiple tooth extractions places him at risk for experiencing endocarditis. He also is scheduled to have all of his remaining teeth extracted, a procedure likely to result in bacteremia. BSB should receive a single 2-gram oral dose of amoxicillin 1 hour before the procedure. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 244.